So we'll begin talking about the normal intestinal microbiome, about mucosal immunologic control of gut infections, and about diarrhea when that control is not yet working. The intestinal microbiome is the complex community of microorganisms that is in the digestive tract of humans and all other animals. The microbiome, and this term refers to the hundreds of trillions of bacteria and other microbes that colonize our bodies and outnumber our own cells by a factor of 10. So each of us is actually the king of a very large or queen of the very large kingdom, which includes not only us and our cells, but the cells of the microbes that live in our intestinal tract. And as long as these microorganisms are controlled by the mucosal immune system, these bacteria do not cause diarrhea or other illness. The mucosal immune system consists of organized lymphoid tissue in the tonsils at the beginning of the digestive tract, what are called Peyer's patches, collections of lymphoid nodules in the small intestine, the appendix, which is between the small intestine and the large intestine, and lymphoid tissue at the end of the digestive tract just above the anus. When I was a medical student and a resident, these features, tonsils, Peyer's patches, appendix, and lymphoid nodules were considered of unknown purpose. Subsequent investigation has shown that they are essential to allow us to live and survive in this world that we share with microorganisms and many other plants, animals. When there are new and unfamiliar microorganisms that are not part of our microbiome can cause diarrhea. And they are taken up by M cells from the organized lymphoid tissue. And that initiates secretory antibody and other immune defenses that normally stop diarrhea after a few days. This is one nodule out of a Peyer's patch. This is the outside surface of the intestine. This is the center of the intestine where food would be going past or any ingested bacteria. These represent villi, which are finger-like projections into the intestine that increase the absorptive surface area for absorbing nutrients. On these lymphoid nodules, there is a specialized epithelium that has cells which have been termed M cells, so that any bacteria that come past can be sampled to begin immune responses. M cells reach out, grab bacteria, pull them in vesicles, and release them below where they come in contact with lymphocytes and macrophages, which then migrate down through the basal lamina into the wall of the intestine, where they multiply and respond to the bacteria, viruses, or other materials that have been taken up from the lumen. Here is a transmission electron micrograph. This is the center of the lumen of the intestine. These are bacteria in the mucus covering the intestine. This is an M cell, which here is grabbing and carrying such bacteria through the wall to the space below the M cell where they come in contact with the lymphocyte or macrophages to begin the immune response. This is thus seen in diagram where M cells are taking up bacteria, and that bacteria then passes through the circulation and throughout the intestine and distributes sensitized cells beneath the absorptive cells, which secrete secretory immunoglobulin A that will then control and modulate any bacteria, viruses, or material that have been ingested. These lymphocytes that are circulating adhere to the walls of blood vessels throughout the intestine, where they are positioned to protect subsequently, presumably for the rest of the life of the person, against that particular strain of microorganism. This colonization of the intestinal tract begins at birth. The intestines of newborn babies become colonized by the intestinal microbiome of the mother. These do not make the baby sick because the maternal secretory antibody in breast milk protects babies from diarrhea, from those bacteria acquired from the mother to which she is immune. The bacteria then form the baby's intestinal, form the baby's intestinal microbiome that helps limit infection with new and potentially disease-causing bacteria. Every time a baby picks up something from the ground and sticks it in his mouth or her mouth, then the baby is actually sampling their environment, and they're building up a library of immune responses against the familiar bacteria in their environment so that those do not produce diarrhea or illness. When materials are eaten and swallowed, they pass into the stomach, where gastric acid destroys most bacteria. It's estimated that if 100,000 salmonella bacteria are ingested, only one will survive and pass through the intestine because of the gastric acid. Now we will begin to talk about diarrhea. Just a little case of diarrhea, not if it's me. If it's me, it's serious. And I'm sure you all feel the same. But infection with new and unfamiliar bacteria that we encounter can cause diarrhea until mucosal immunity has a time to develop against that specific new organism. Diarrhea is the second leading cause of death worldwide. It's the most common cause of morbidity and mortality in children worldwide. Diarrhea accounts for 9% of hospitalizations in children less than 5 years of age in the United States, and presumably in Cameroon and elsewhere. You and your patients will likely suffer from diarrhea in the near future. There is geographic variation in intestinal pathogenic bacteria. The types and percentage of bacterial pathogens vary around the world, related to water and food sources, sanitation levels, and local customs. Although the data I present are derived from the United States, ever-increasing international travel means much of what I present will also be relevant to other areas. An example of the impact of travel on bringing people and cultures together is the handsome Saya Bacham dance headdress from Cameroon. over my shoulder that was given to me many years ago by one of my professors. If anybody in the audience has ever seen such a mask and has any familiarity, you can send me an email and tell me about it. All I know is it's beautiful and is part of my day-to-day life. Bacterial pathogens occur in, see, I can't see exactly, in descending order of rates per 100,000 people in the US in 2012 are shown below. Salmonella, out of 100,000 people, 6.4 cases. Campylobacter, 14.3. Shiga toxin producing Escherichia coli, 1.1 case, and smaller numbers of Vibrios and Yersinia. This is from a review article from the New England Journal. The diarrheal disease mortality around the world is shown in this chart. The most numerous incidences of death relating to diarrhea occur in the Indian subcontinent and in Africa, particularly in West Africa. This shows United States Marines getting paid to bring in samples of their stool for analysis in Iraq back in 2004. The Naval Medical Research Division has been collecting and testing stool samples to determine if the behaviors of the bacteria encountered in Southwest Asia and Afghanistan are different, and how those bacteria affect people in different parts of the world. This is important because the history of, throughout history, diarrhea has been one of the leading causes of slowing troop movements and degrading fighting forces. So they say that it's very hard to be working, traveling, or doing anything else if you have your pants down because you have diarrhea. Our objectives today are to review the epidemiology and most common bacterial etiologies of diarrhea. We will discuss specific characteristics of the most common bacterial pathogens, and we will identify the most important aspects of the history and physical in patients with diarrhea. I will briefly discuss laboratory evaluation, but more treatment of diarrhea. What we will not cover today is viral diarrhea, even though that's the most common cause of diarrhea worldwide. Fortunately, the mucosal immune system handles and controls viral diarrheas usually within a week. We also will not discuss parasitic diarrhea that varies by geography around the world. I will not talk about non-infectious diarrhea, traveler's diarrhea, Clostridium difficile diarrhea, which is most problematic within a hospital setting, or diarrhea in patients who are immunocompromised, as in those patients with HIV infection. I will also not talk about the specific treatment of severe diarrhea requiring hospitalization. The definition of diarrhea, and we all, of course, know what diarrhea is. We've all had diarrhea. But for scientific studies and for investigation, it is necessary to have a definition. And the agreed definition is stool weight in excess of 200 grams per day, 3 or more loose or watery stools per day, alteration in normal bowel movement characterized by decreased consistency and increased frequency. And it's defined as acute diarrhea if it is lasting less than 14 days. Epidemiology. Normally, we all have 1.2 to 1.9 episodes of diarrhea a year. Having diarrhea more frequently than that is prevented by the acquired immunity and the mucosal immune response, and is related, of course, to the types of exposures each of us have. As physicians and healthcare workers coming in contact with ill persons, it is therefore a risk that we will acquire diarrhea from our patients. However, with careful hand washing and hygiene, that can be minimalized. The diarrhea is more frequent in children than in adults because they do not yet have immunologic experience with common bacterial pathogens. And also, as I said, small children explore their world by putting everything they find in their mouth. Statistically, there are usually more episodes for children if they, as they are older than 3 years. When they are older than 3 years, they begin to move around on their own and encounter other children and contaminated materials in the outside world that expose them to new microorganisms that they did not acquire from their mother. As I said before, 70 to 80% of infectious diarrheas are caused by viral agents. Bacteria cause 10 to 20% of infectious diarrheas, but are responsible for most cases of severe diarrhea. Protozoa, such as amoebiasis, cause less than 10% of diarrhea in the United States, but that's higher in areas with limited access to clean water sources. Of the bacterial diarrheas, I will talk about 4: Campylobacter, Salmonella, Shigella, and diarrhea-producing E. coli. Campylobacter is, at least in the United States, the most common bacterial pathogens. It is transmitted through ingestion of contaminated food or by direct contact with fecal material. Symptoms include diarrhea with or without blood, abdominal cramps, which can be severe, malaise, and fever. Is usually self-limited as the mucosal immunity develops, and it does not require antibiotics in most situations. Salmonella is most common in children less than 4 years old, and it peaks in the first few months of life. As children become familiar with the microorganisms in their immediate environment, they have many episodes of brief diarrhea, and that is as they began to develop and expand their immunologic experience with common microorganisms. These are transmitted, the salmonella, by ingestion of contaminated food and contact with infected animals, including pets. And here in the United States, there was some problem with people, with children having pet turtles, and they put the turtles, like everything else, in their mouth and can become infected with salmonella. Major vehicles of transmission are foods of animal origin, including poultry, chickens, beef, fish, eggs, and dairy products. The symptoms of salmonella infection include fever, diarrhea, and abdominal cramps. Antimicrobial therapy can actually prolong fecal shedding rather than shorten the infection. And it is, however, recommended to use antibiotics for those with increased risk of invasive disease passing out of the intestinal tract into the general circulation. And that is in infants that are less than 3 months of age, and patients with chronic gastrointestinal disease, or patients who are immunosuppressed, such as with HIV. Complications can include bacteremia, osteomyelitis when salmonella affects the bones, and meningitis when the brain and nervous system are involved. Shigella is, like the other bacteria we were discussing, transmitted by fecal-oral contact. It affects people of all ages, and the predominant modes of transmission include person-to-person contact, contact with contaminated objects, and ingestion of contaminated food and water, and sexual contact, which brings people close together and includes sharing of microorganisms. Symptoms of Shigella include fever, abdominal cramps, tenesmus, which is straining very hard to produce a stool, and mucoid stools with or without blood. Most infections are self-limited by mucosal immunity and do not require antibiotics. Antimicrobial treatment may shorten the duration of illness and does limit fecal shedding, but is usually not necessary and may produce more drug-resistant strains in a community. Rare complications include bacteremia, toxic megacolon, and intestinal perforation, and toxic encephalopathy. The E. coli producing diarrhea, the only kind that commonly causes severe diarrhea in the United States is what is known as hemorrhagic E. coli O157H7. And these characterizations, O and H, are from old German terms referring to whether the bacteria have cilia or little fibrils coming off of their surface. O means without these little hairy particles, H means with. The nomenclature varies when describing all the different kinds of E. coli, and some are referred to as verotoxin producing E. coli or VTEC, enterohemorrhagic E. coli or EHEC, Shiga toxin producing E. coli or STEC. Dr. Shiga in Japan originally described this, and consequently this toxin producing E. coli strain remembers him by being known as Shiga toxin producing. E. coli that cause human gastro and illness include the Shiga toxin producing or enterohemorrhagic E. coli. There are also the enteropathogenic, which damage the wall of the intestine, enterotoxigenic, which have their effect by producing a toxin that stimulates more diarrhea, enteroinvasive E. coli, which penetrate the wall of the intestine and spread through the body, and other types that are less well characterized. The Shiga toxin producing E. coli are a particular problem because of the Shiga toxin. And there are some of the Shiga toxin E. coli which do not have the O157 type. There are many types of Shiga toxin producing E. coli. More than 100 have been identified, but they are less problem than those that produce the Shiga toxin. The diagnosis of Shiga toxin E. coli is made by a laboratory testing, and this depends on the availability of a laboratory that is able to do the test for toxin. And knowing what the specific strain is important for public health purposes and for identifying outbreaks as being related to a particular contaminated food type, but it's not necessary for treatment of an individual patient. And to determine the type of Shigella, strains must be sent to a regional or national public health laboratory that has the ability to do such a test. Transmission is from ingestion of contaminated food, especially undercooked ground beef, dirty water, and unpasteurized milk. Symptoms include bloody diarrhea, severe abdominal pain, and sometimes fever. This can lead to serious complications. Antibiotics have no proven benefit and may actually increase the risk of complications. The major modes of transmission of E. coli, or how the fecal material gets to the mouth, often in food that is contaminated, food coming from cattle, which means the meat, the raw milk, or food contaminated with cattle or animal feces, such as lettuce and other vegetables that are eaten raw, and water, both drinking water and recreational water, because when people are swimming or bathing in fresh water, they may swallow some of the water that they're swimming in or bathing with. It also happens with animal contact. Those persons who are in contact with farm animals or wild animals or their environment. And the most common is person-to-person contact, when the feces of an infected person or contaminate the hands or fingers of a person and then pass into the mouth and are swallowed. One of the severe complications with this type of bacterial infection is what known as the Hemolytic Uremic Syndrome. And it causes a particular type of hemolytic anemia in which blood cells are destroyed, or thrombocytopenia, which can lead to more bleeding as thrombocytes are damaged or destroyed by this bacteria, and then subsequent kidney failure or renal dysfunction. The hemolytic uremic syndrome occurs in about 8% of children with enterohemorrhagic E. coli infection, and usually presents about 2 weeks after beginning of the diarrhea. Thrombocytopenic purpura, which is purplish spots in the skin because of passage of blood out of blood vessels into the skin, in adults is the same disease as the post-diarrheal hemolytic uremic syndrome in children. And patients with bloody stool should have a complete blood count or CBC and renal panel to evaluate for hemolytic uremic syndrome or thrombocytopenic purpura. If no laboratory abnormality is present 3 days after resolution of diarrhea, the future risk of developing hemolytic uremic syndrome is fortunately low. This shows the identified cases of non-O157 Shiga toxin producing E. coli as stereotyped by the Center for Disease Control in the United States. And you can see that over the years, the number have been increasingly identified. This does not necessarily mean that there are more cases of diarrhea with this occurring, but that the labs are becoming more skilled at detecting this particular strain. Looking at outbreaks of diarrhea with this strain of E. coli from 1990, when there have been outbreaks in a community and the source has been found, was found to be such things as milk, lake water, a salad, punch drink, daycare setting, lake water, apple cider, or an infected food handler not washing their hands adequately before preparing food, or from daycare centers. The sequence of events is that this bacteria is somehow ingested, and 3 or 4 days later, the person develops non-bloody diarrhea and abdominal cramps. 1 or 2 days later, they may develop bloody diarrhea, which in 92% of patients will clear up on its own. But 8% of those patients with bloody diarrhea can develop the hemolytic uremic syndrome. With the non-O157 strains, it is similar. 3 to 4 days after ingestion of the bacteria, the person develops non-bloody diarrhea and abdominal cramps, which progress in 1 to 2 days to bloody diarrhea, but 98% resolve with no further problem, and only very rarely does the hemolytic uremic syndrome develop. So those persons with non-O157 Shiga toxin producing E. coli have less severe illness. But the non-O157 strains can include many serogroups with varying virulence. Some only cause mild diarrhea, others can cause more severe problems. So in summary, looking at bacterial diarrheas, they can affect all age groups. Fecal oral transmission, often through contaminated food, is the source of this infection. Typical symptoms include bloody diarrhea, cramps, and malaise. Antibiotic treatment is not always necessary and may actually make the situation worse, if not really required by the situation.